My name is Panita Tandon. I'm a gastroenterologist and hepatologist at the University of Alberta Hospital in Edmonton, Alberta, Canada. And I'm pleased to present you with a video summary of our findings from our study looking at antibiotic-resistant bacterial infections in patients with cirrhosis. This work was done at the Yale New Haven Hospital in Connecticut under the supervision of Dr. Guadalupe Garcia-Sao and with collaboration by Angela Delisle, who's a nurse practitioner, and Dr. Jeffrey Topol, who is an infectious disease specialist. So why did we choose to do this study? Well, we know that bacterial infections are a leading cause of morbidity and mortality in patients with cirrhosis. And the development of antibiotic-resistant organisms is really compromising our first-line antibiotic therapy choices. Fernandez et al. From Spain found high rates of antibiotic resistance in their cirrhosis-related infections. This led the Spanish group to recommend broadening their empiric antibiotic coverage in patients at high risk. As Spain is known to have a discordantly high rate of antibiotic resistance, however, and as there was limited North American data, before generalizing these recommendations to broaden empiric antibiotic coverage to our local patients, we chose to undertake an evaluation of the prevalence and predictors of antibiotic resistance at a tertiary care North American center. So how did we go about doing this? We identified all cirrhotic patients admitted to the Yale New Haven Hospital liver unit between July 2009 and November 2010. From those patients, we selected those that had developed bacterial infection either at admission or during the course of their stay in hospital. For the primary analysis of outcomes, we looked only at the first infection per patient. We did collect data on repeat infections and used that to perform a secondary analysis. As per standard criteria, nosocomial infections were defined as those developing greater than 48 hours after admission to the hospital. All other infections were considered to be community acquired. Non-absorbed antibiotics, such as rifaximin, were distinguished from systemic antibiotics in order to determine their relative impact on the development of bacterial resistance. The complete list of organisms that we considered to be resistant to antibiotic therapy includes the commonly seen pathogens VRE, MRSA, quinolone-resistant gram-negative rods, and ESBL. So what were the study results? Of the screened cirrhotic patients, 115 had bacterial infection. 68% were male, with a mean age of 56 years. Spontaneous infections, namely spontaneous bacterial peritonitis, spontaneous bacterial empyema, and spontaneous bacteremias, were the most common infections found in 35% of patients. Urinary tract infections were the next most common at 32%, and pneumonia was the third at 19%. 61%, or 70 of the 115 bacterial infections, were culture positive. And of that, a striking 47% were due to antibiotic-resistant organisms. The most common antibiotic-resistant organisms in our series were vancomycin-resistant Enterococcus, ESBL, and quinolone-resistant gram-negative rods. Next, we evaluated for predictors of infection with antibiotic-resistant organisms. On multivariable analysis, exposure to systemic antibiotics within 30 days preceding the bacterial infection was the only independent predictor of resistance to antibiotic therapy. Importantly, on univariate analysis, exposure to non-absorbed antibiotics such as rifaximin were not an important predictor of antibiotic resistance. So we then went on to evaluate predictors of resistance to first-line antibiotic therapy. And this was done in the select group of 60 patients who either had spontaneous infections or urinary tract infections. First-line antibiotic therapy for the spontaneous infections was considered to be third-generation cephalosporin antibiotics, and for the urinary tract infections was considered to be ciprofloxacin. So when we did that multivariable analysis, two independent predictors emerged: nosocomial acquisition of infection and exposure to systemic antibiotic therapy within the preceding 30 days. We then went on to do a secondary analysis using 169 original and repeat infections, and that confirmed the findings of our primary analysis. So what can you take home from this? Well, first, our study confirms that in a series of cirrhotic patients admitted to a tertiary care transplant center in North America, the prevalence of infection with antibiotic-resistant organisms is high. Of all the culture-positive infections, 47% were caused by antibiotic-resistant organisms. Moreover, a striking 39% of the culture-positive spontaneous infections were resistant to third-generation cephalosporin antibiotics. Secondly, we determined that non-absorbed antibiotics such as rifaximin do not increase the risk of infection with antibiotic-resistant organisms. Thirdly, two variables emerged as being important in the prediction of infection with an antibiotic-resistant organism and in the prediction of resistance to first-line antibiotic therapy. First, exposure to systemic antibiotics within 30 days of the bacterial infection, and secondly, nosocomial acquisition of infection. Fourthly, the relative contribution of different types of systemic antibiotics, for example, those antibiotics used for prophylaxis against spontaneous bacterial peritonitis versus broader spectrum systemic antibiotics, was not clearly evaluable in this study and will require further study. So how can you use this clinically at the moment? Well, with the caveat that rates of antibiotic resistance may be lower in smaller centers, we all need to be cognizant of the potential for resistance to our prescribed antibiotic regimens. The ICU literature has very clearly demonstrated that when patients are treated with ineffective antibiotics, this results in increased rates of septic shock and death. We support the recommendations of the Spanish authors to use an even broader spectrum class of antibiotics, such as the carbapenem class, for the treatment of nosocomially acquired infections. Whether all patients exposed to any systemic antibiotics within the past 30 days should also get broader spectrum coverage remains unclear and will require further study. As per standard infectious disease principles, however, those patients who have been exposed to a third-generation cephalosporin antibiotic within the last month or who have had recent infection with organisms known to be resistant to third-generation cephalosporins should have broader empiric coverage. Thank you for your attention during this short presentation.